I was debating along with my neuro ICU colleague who's from New York, Dr. Melmit. We were debating this particular issue about blood pressure lowering after brain hemorrhage and how low can we go and should we go low. So I was debating on the pro position, saying yes, we should go low, and she was debating on the you shouldn't go too low position. We had a ball of a time debating it this morning. And brain hemorrhage is something that I'm extremely passionate about. I've been working in this field for over 2 decades now. And I've seen the field kind of move from being a condition where there's a lot of nihilism associated to it, where, once you have a brain hemorrhage, you say, oh my God, we can't really improve your outcomes. And the field has really moved towards, yes, we can improve outcomes, and here are some strategies and tools and ways to do it. So it's been very exciting to watch this journey, over 20 years. So if I might take a step back, once you have a brain hemorrhage, what we know physiologically happens is that a third of patients at least will have expansion of the bleed in the brain. So it's not a one-time event. It continues to accrue and grow in the brain, and it happens pretty fast in the first 2 to 3 hours for those who are going to expand. And we can categorize patients into those who expand a lot, to those who expand a little bit, and those who don't really expand. And so any kind of therapies that we provide, like really upfront, is going to have what I call most bang for the buck. So blood pressure lowering is associated, or blood pressure that's elevated is associated with hematoma expansion, and hence the movement towards lowering the blood pressure, and then pushing the field forward and seeing how low can we actually go to give the most benefit for our patients by limiting the amount of hemorrhage that is expanding. So you asked me about what data and what literature we have about it. There were 2 very big randomized trials done for blood pressure lowering. One was called Interact-2, and the other one was ATAC-2. And both of them looked at 2 different blood pressure targets. In Interact-2, the lowest patients got was about 130, and in ATAC-2, patients got below 130. Even though those 2 trials were not significant for their primary endpoint, and there's a lot of reasons why they were not, when those 2 numbers were pooled together to create a much larger, meta-analysis, it was very clear that you can very safely lower your blood pressures beyond what is being currently advocated. And so that was the evidence that I was able to dissect and present, to the audience today. And the key reason why these 2 trials didn't really meet their primary endpoints was the therapies for blood pressure lowering was started late, meaning after the hematoma had already expanded. So you couldn't really see a signal very much on the hematoma expansion. But when you look at this overall population, and especially in those patients where you have the blood pressure lowering early on, you can definitely see an improvement in their outcomes and a decrease in the hematoma expansion. So that's kind of the data that I presented this morning to make my case that yes, you should go low and you can go low. The particular patient populations that can benefit really from, a lower blood pressure target would be those who don't actually come in with prior history of significant hypertension. So let's say you have a younger patient who's coming in with a bleed, and they come in really fast, within 30 minutes, an hour of their symptom onset. In those patients, we can lower it very intensely, very aggressively, without any concerns. Patients who come in that early time period, again, stand to benefit the most from the blood pressure lowering. It's not to say that you can't lower your blood pressure after 2 or 3 hours. You should still do it, but you need to get there fast, and most importantly, minimize sort of these fluctuations and variabilities, because that's been associated with worse outcomes. So in particular, if we want to talk about a group of patients that are going to be most benefited by intensive or aggressive blood pressure lowering, it would be patients who are coming in very early on after their symptom onset, younger patients.